The COVID-19 Immunity Task Force and CanCOVID have partnered on a monthly event series, Research Results and Implications, to offer researchers, policymakers, and Canadians with the latest COVID-19 related results. To learn more about how both organizations have been helping to inform public health policy during the COVID-19 pandemic, please visit our websites at covid19immunitytaskforce.ca and cancovid.ca.
Welcome everyone to the 7th CITF CanCOVID Seminar Series event. My name is Tim Evans. I'm the Executive Director of the COVID-19 Immunity Task Force, and I'll be your moderator today. Before we get started, I've been asked to share some instructions as we're providing simultaneous translation into French, and we'll have a bilingual question and answer period. Bienvenue à tous et à toutes au 7e événement de la série du séminaire GTIC CanCOVID. Mon nom est Tim Evans, directeur administratif du groupe de travail sur l'immunité face à la COVID-19. Je serai votre modérateur aujourd'hui. Avant de commencer, on m'a demandé de partager quelques instructions car nous offrons une traduction simultanée en français et nous aurons une période de questions et réponses bilingues. At the bottom of your Zoom screen, you will see an icon of a globe. Choose off if you are bilingual and want to only hear the live feed. English attendees, you should select the English option. So you can hear the entire event in English. The presentation will be in English, but the question and answer period will be bilingual. When questions are asked in French, our panelists will answer in French if a French-speaking panelist can answer that question. Au bas de votre écran Zoom, vous verrez l'icône.
At the bottom of your Zoom screen, you'll see a globe icon. Please choose off if you're bilingual and you wish to listen only to the source audio. Our Francophone participants should select the French option in order to listen to the whole event presentation in French. The presentation will be presented in English, and the question and answer period will be bilingual French-English. Those questions asked in French will attempt to answer your questions by a French-speaking panelist if they're able. Please select your preferred language right now.
So I will begin, and I hope everybody has got the logistics. A little background on the COVID-19 Immunity Task Force. We support studies related to the nature and magnitude of immunity that's found across Canada, starting back with the first wave over 2 years ago, and continuing into the vaccine era that we find ourselves at the moment. We've supported 113 studies across the country, and as you can see, these are some of the touchdown points across our provincial territorial jurisdictions. Next. Vaccine safety, which is the focus of this seminar, is really a critical component of vaccine surveillance, and about over a quarter of the CITF's studies have really focused on vaccine surveillance. And this is a recognition that in moving towards approval of vaccines, there's a very stringent and rigorous clinical trial process, and that is capped by an approval process at Health Canada. And all of the COVID-19 vaccines that have been approved over the last 2 years have moved through these well-established processes for assessing safety and efficacy of vaccines. And then the CITF, through something called the Vaccine Surveillance Working Party, as the vaccines have been rolled out, has supported further assessments of vaccine safety and effectiveness, working in collaboration with key agencies that are part of the institutional apparatus to ensure vaccine safety that include Public Health Agency of Canada, the Canadian Immunization Research Network, and the National Advisory Committee on Immunization. Next slide. I think the good news is that adverse events due to COVID-19 vaccines are in fact very rare. Over the last year and a half, we've had nearly over 82 million vaccine doses administered in Canada, clearly the largest vaccination program ever. And when we've looked at the total adverse events following immunization, it's 0.054%. The vast majority of these are not serious. And of the serious ones, it diminishes to 0.011%. And when you look at the number of deaths as a percentage of that, it's an even smaller fraction, 0.00027%. And of those deaths, it's not really clear the extent to which those are directly related to the vaccine. So these are the data that have been pulled together as recently as April 8th, and just as an indication that there's ongoing monitoring of the serious and non-serious events arising from vaccination. Next slide. So to get us much more into depth on this topic, we have a fantastic set of speakers today who are all experts in the field and actively involved in monitoring vaccine safety. We'll begin with Scott Halperin, who's a professor at Dalhousie University. He's the principal investigator of the Canadian Immunization Research Network, CERN, and he's also a member of the CITF Leadership Group and chair of our CITF Vaccine Surveillance Working Party. Scott will be followed by Julie Bettinger, who's a professor at the University of British Columbia. She's also a principal investigator with CANVAS, the Canadian National Vaccine Safety Study, which is part of the Canadian Immunization Research Network, CERN, and she's also supported by the CITF. Julie will be followed by Karina Top, who's an associate professor at Dalhousie University. Karina is also a principal investigator for the Special Immunization Clinic Network of the Canadian Immunization Research Network, and she's also a co-PI in the Canadian Immunization Monitoring Program, ACTIVE, also known as IMPACT, and she's also supported by the CITF. And finally, following Karina, we'll have Jeff Kwong, who's a senior scientist at ICES and also a scientist at Public Health Ontario, a professor in the Department of Family and Community Medicine, and also at the Dalla Lana School of Public Health at the University of Toronto. And Jeff is also supported by the CITF. So 4 great speakers, and I will now pass la parole to Scott Halperin.
Great, thank you, Tim. And just some disclaimers. Next slide. So what I'll do is over the next couple of minutes is just briefly set the table for what Julie, Karina, and Jeff will be discussing in terms of the Canadian data. When one looks at, as of about a week ago, over 5.6 billion people have received a dose of COVID vaccine worldwide, which corresponds to about 2/3 of the global population. And about double that, so 11.5 billion doses have been given. Next slide. Within Canada, over 83 million doses have been administered in Canada as of mid-April, which was 32.5 million first doses, 31 million second doses, and 18 million third doses. And this corresponds to about 85% of the total population in Canada having received 1 dose and 81.4% being fully vaccinated with a 2-dose series. In children, and if you include children, 89% of the population over 5 years has received at least 1 dose, and 85.6% are fully vaccinated. Next slide. So there are a number of vaccine perceptions or misperceptions that may be driving some of the vaccine hesitancy and why we're not even higher in those proportions. Some of those perceptions are that it's a new virus and a new vaccine, and that makes people nervous. It's new technology. Most of the vaccinations that have been given in Canada are the messenger RNA vaccines, which is new technology. There are concerns that there were rushed approvals or shortcuts that took place, such that the vaccines were rolled out using an emergency use authorization process rather than full authorization by the regulator. And finally, there's been politicization of vaccines and vaccination with issues around the freedom to choose and the controversy of mandates. Next, please. The reality is that while it's a new virus, a lot of lessons were learned from the SARS-CoV-1 virus, and a lot was known about the virus. mRNA vaccines were previously used in clinical trials for over 10 years, but it is correct that these are the first fully authorized mRNA vaccines for COVID. Approval of vaccines in under 10 months is what we found, compared to 5 to 10 years. And this is, this was done by sort of the moonshot strategy of all resources being focused on the development of COVID vaccines. There were also regulatory efficiencies and adaptive clinical trial designs that made up for this shortening of the time frame. And from politics, there was a lot of spillover from the US and further polarization following vaccine mandates, and really a breakdown of the unified approach that we saw in the earlier stages of the pandemic. So the next slide from the US, this is a New Hampshire license plate with their motto of live free or die. And then some of the protests, I think what we're finding is, next slide, it's live free and die. Next slide. When one looks at the reality of safety, if one looks at adverse events following immunization, and I'm going to just talk about some of the common adverse events, most adverse events are mild, and the mild adverse events are frequent. There's no doubt about that, and moderate adverse events are common. Adverse events appear to be more common after the mRNA vaccines than after the viral vectored or inactivated virus vaccines. But most of the adverse events after all of the COVID vaccines are mild to moderate in severity, with very few of them being rated as severe adverse events. There's no clear pattern between the first and second doses as it increased in adverse events, and serious adverse events are rare. And these vary by type. So anaphylaxis was seen in the mRNA vaccines. The adenovirus vectored vaccines were associated with venous thrombotic events and thrombocytopenia, and talking more about myocarditis and pericarditis with the mRNA vaccines. Importantly, though, there is more active vaccine safety surveillance in place in Canada and globally, in fact, than for any prior vaccine. So enhanced surveillance was put in place. And so we know much more about adverse events following immunization with these vaccines than many of our common vaccines, which we rely on passive systems. And what the rest of the speakers are going to be talking about are these enhanced surveillance systems. Next slide. If one looks at injection site reactions, these are the common things that the people in the public experience and they know. These are from clinical trials, which showed that pain at the injection site was reported mild or moderate by over 80% of people, but severe pain was quite infrequent. And you can see that there's no increase after the second dose. From the next slide, if one looks at systemic adverse events, fatigue, headache, and chills, and muscle pain is quite commonly reported. But again, very little difference between the first dose and second dose, and most of them are in green and blue, are mild or moderate. Serious adverse events in the clinical trial were less than 0.4%. None were associated as related to the vaccine. This was the mRNA vaccine. There was no thrombosis and no hypersensitivity reactions. Next slide. Tim, back to you.
Many apologies. I was speaking to myself. Thank you very much, Scott. And now we move on to Dr. Julie Bettinger. Julie?
Great. Thanks, Tim. Could I have the next slide, please? Great, thanks. So I'm Dr. Julie Bettinger, and I am coming to you today from the traditional and unceded territories of the Coast Salish people, where I have the privilege to live. Next slide, please. So I'm going to talk today about our Canvas COVID surveillance, and this is an outshoot from our existing Canvas influenza surveillance, which has been in place since the H1N1 pandemic, influenza pandemic in 2009. And with the advent of COVID and COVID vaccines, we pivoted to monitoring the safety of COVID vaccines with this surveillance network. So currently we have over 1 million participants enrolled in 7 provinces and territories across Canada. And we capture information on our participants in terms of their age, the type of vaccine they received, so whether it was Pfizer or Moderna, AstraZeneca, their health status, and whether or not they were previously infected with COVID and whether or not they're currently pregnant. So the way it works is that we send a survey the week after their first dose of vaccine, the week after their second dose of vaccine, and then we have one final survey that goes out approximately 7 months after they received that first dose of vaccine. And we're capturing what we have called severe health events. But what we mean by that term is really any event that is severe enough to cause work or school absenteeism, prevent normal daily activities, or require a medical visit. And this medical visit can range from a call to the nurse health line to a hospitalization. What's unique about Canvas COVID is that we actually have a control survey of unvaccinated individuals that captures the health events occurring in this population over a 7-day period as well. So essentially, we can compare events happening in our unvaccinated group to events that happen in our vaccinated group. And then for both of our groups, anyone who does have a medically attended event, we do follow up by telephone to solicit more information about that event. Next slide, please. Okay, so I'm going to focus first on our pediatric results, and these are available on our website with the link here on the slide if you'd like to check it out further. But this information is as of April 20th, and we generally update it about once a week. So what we see with our kids surveillance is we have about 250,000 parents of children who have completed the survey following their dose 1 vaccine, and we have about 125,000 who've completed the survey following dose 2. So that's our sample groups. Next slide, please. The events that we're seeing in this group with the Pfizer vaccine is about half of all kids have an injection site reaction. So this would be swelling, pain, or redness at the site of injection. And this is almost equal after dose 1 and dose 2. What I think is really important to note is that after dose 1, over 94% of that 250,000 participants did not develop any other health symptoms. So they only had that injection site reaction. 96% did not have any new health event as the severe health event. So an event that prevented daily activities, school, or required a medical visit. And the numbers are quite similar after dose 2 as well. So it's 95% didn't have anything after dose 2, and 97% didn't have any type of an event that would prevent their daily activities. Next slide, please. So what do we see in terms for that very small group, so the 4% and the 3% who are reporting events? So about 3% report flu-like symptoms, and this tracks with what Dr. Halperin showed you from the clinical trials. So this would be things such as fatigue, muscle aches, feeling unwell. We have another about 2% after each dose who are reporting headaches or migraines, and then about 1.5% who are reporting nausea, vomiting, and diarrhea, and then about another 1.5% who have a fever. So again, these events track very similarly to what we saw after the clinical trials, and it's actually very reassuring that we're seeing sort of what we would expect in a very large population of children. Next slide, please. So I think from these preliminary data, what we can conclude is that the Pfizer vaccine is very well tolerated in children. Back over to you, Tim.
Great. Thank you very much, Julie. And we're now going to move on to Dr. Karina Top. Karina?
Great. Thanks, Tim. So next slide. So I have no conflicts of interest relevant to this presentation. Next slide. So I'm going to briefly mention today our active surveillance that we're doing for serious adverse events following immunization in children across Canada. So these are adverse events that lead to hospitalization or emergency department visit. And the objective impact is a project that has been ongoing since 1991, and currently 13 centers, pediatric hospitals across Canada are involved in our COVID vaccine safety and effectiveness study. Our objectives are to determine safety of COVID vaccination among children up 0 to 16 years of age with respect to myocarditis and pericarditis, multisystem inflammatory syndrome in children, and febrile seizure. And these events are chosen either in the case of myocarditis because they were associated with COVID vaccination, and for the other two, they have the potential to be associated with COVID vaccination, but have not yet been seen in significant numbers. And the second is to evaluate trends in SARS-CoV-2 infection, COVID-19, and MIS-C among those same hospitalized children before and after the introduction of vaccination programs. And so this is active surveillance, which means that we have nurses who screen hospital admission lists every day and emergency department visits. And that started in June 2021 and will continue till December 2022. They collect data on all cases that meet our case definitions, and as well as immunization status, history of SARS-CoV-2 infection, and outcomes after hospital discharge. And then we'll be analyzing those cases to look at whether there's clustering of certain adverse events immediately after a vaccination compared to a background rate remote from vaccination. And important to note that all of the adverse events that impact identifies are also reported to the CAFIS passive surveillance system. Next slide. So I show this to emphasize that impact is contributing to the CAFIS national database and the data that is published online. Next, please. And as shown here, despite this, even with this increased surveillance, we're seeing far fewer adverse event reports in children under 18 years of age than in any other age group. Next slide. And impact has historically been the source of about 50% of serious adverse event reports to CAFIS, the public health agency. And this is showing the overall reporting rates in black and the serious reporting rate in yellow per 100,000 vaccine doses administered for 5 to 11 and 12 to 17-year-olds. And you can see those rates of serious adverse events are very low, less than 10 per 100,000 doses and lower than in adults, even with this added surveillance. So again, emphasizing how safe these vaccines are among young children.
Thank you very much, Dr. Top. And so let's move from COVID-19 vaccine safety in children to adults. And here we see that the pattern is slightly different. And perhaps, Dr. Top, you can report on your study called the Special Immunization Clinic to give us some ideas on what CITF has funded with respect to the adult population. over to you.
Great, thank you, Tim. Next slide. So the Special Immunization Clinic Network, as was mentioned, is a network within CERN. The objectives of this study are to standardize clinical care of people who have had a medically significant adverse event following COVID-19 vaccination, in particular one that comes to medical attention and raises concern about safety of giving further vaccination doses, and to determine the rate of recurrence of adverse events following revaccination with COVID vaccines. So we have centers across the country, as shown in the figure, and patients who've had an adverse event that came to medical attention are referred to one of our sites for assessment, really to help, in some cases, to help confirm a diagnosis, but more often to explore the possible causes of that new health condition, its relation. Oh, please go back. Can you go back, please? Yeah, if you could go back, thank you. To assess patients regarding the risk benefit of receiving further vaccinations, and then we follow up at everyone who's recommended for further doses to capture if they developed any adverse events following that next dose. We also have standard approaches to evaluating specific adverse events of interest, such as allergic type reactions and myocarditis. As of January 2022, with about 13 months of enrollment, we had enrolled over 318 patients. And we're continuing to see patients through this network and follow them up. Next slide. So most patients that we've seen so far were female, about 2/3, and many were 40 to 64 years of age. As of January, we had no patients enrolled so far who were under 12, and only a small number between 12 and 17. Next slide. And so in terms of the types of adverse events we were seeing, the most common by far were hypersensitivity reactions or possible allergic reactions. We also, through the summer, started to see an increasing number of referrals for patients with myocarditis and pericarditis after both mRNA vaccines. And next. And we also saw a range of other types of adverse events, including patients with immunization stress-related responses, so stress reactions to vaccination that often mimicked anaphylaxis, and that prompted the referral. Next slide. So most patients that we're seeing so far were recommended to continue with the next dose of vaccination. And of those that have been revaccinated so far, the largest group are those with hypersensitivity reactions. So our allergists really had many referrals and were overwhelmed with referrals really in the early months of the vaccine rollout because of people presenting with symptoms that could have been allergic reactions, though most were not. And of those that were revaccinated, over 80% had no further adverse event. And we had just 18% recurrences among those who were felt to have had some sort of hypersensitivity reaction. And most of those were mild to moderate severity and none required hospitalization. Next slide. So there are some limitations to the data I've shown. So there are differences in referral practices between sites, and there is some selection bias. So we were, as I said, overwhelmed with referrals, and so we prioritized people who had reactions after their first vaccine dose to help advise on what to do about completing the primary series, and then are working through the referrals for people who need booster doses. And there is also variation in the workup and recommendations by site and physician, or even, patient specific, because each patient is a bit different. But overall, what we found is that most people with adverse events following COVID vaccination seen in our clinics were safely revaccinated. And we have plans underway and are to analyze specific groups of patients with specific types of adverse events that will be, we look forward to sharing those results over the coming months.
Thanks very much, Dr. Top, for those results. And now we're going to move on to Dr. Jeff Kwong. Jeff, over to you.
Okay, this is not my slide. Oh yes, there we go. Thank you. So if we could have the next slide, please. And I have no conflicts to disclose. And next slide, please. So multiple countries have reported increased myocarditis or pericarditis risk after mRNA vaccines. And this is especially so for adolescent and young adult males after the second dose and with the Moderna vaccine. So those are fairly well established. However, there's limited data comparing the risk of myocarditis or pericarditis after vaccination as compared to after SARS-CoV-2 infection, or looking at the risk by dosing interval. So the graph on the right is just showing that data from Israel showing that there seems to be increased risk of myocarditis after infection, and also pericarditis after infection compared to after vaccination. So you can see that the orange bars, the risk ratios are higher in the orange compared to the blue. Okay, next slide, please. So it's also important to keep in mind the background rates of myocarditis and pericarditis. So here we have data from Ontario, where we can see on the x-axis the different age groups, and then the y-axis, the vertical axis, you can see the incidence rate per 100,000. So this is all data using from 2015 to 2019, so before the pandemic. These are hospitalizations or emergency department visits due to either myocarditis or pericarditis seen in Ontario. And so you can see the green lines are for males, and they're higher than the blue lines, which are for females. And the solid lines are for pericarditis, and the dashed lines are for myocarditis. So you can see that in males in the late teens, you can see that there's much higher risk of both myocarditis and pericarditis compared to females. And then the risk is elevated until kind of around 50-something for myocarditis, and then it remains higher for males than females, all for all age groups above about 12. So just keep this in mind as when we see higher rates of myocarditis and pericarditis in males and in teens and younger adults. You have to keep, after vaccination or after infection, you have to keep in mind the background rates. Next slide, please. So the objective of our study was to evaluate whether the incidence of myocarditis or pericarditis after receiving an mRNA vaccine as a second dose varies by the dosing interval. So we, because in Canada we had a range of the dosing intervals because we had a shortage, and then that led to like a shortage of vaccine, and so we had to use longer dosing intervals. And then when we had more supply, we went back to shorter dosing intervals. So we have this variability in Canada, which allows us to look at the risk of myocarditis or pericarditis by dosing interval. And then also we want to look at it compared to SARS-CoV-2 infection, because it helps put the risk into context. Next slide, please. So what we used was health administrative data from 3 provinces, so British Columbia, Ontario, and Quebec, and we limited it to those who are living in the community. So we excluded residents of long-term care, and we also studied those who are aged 12 years or older. We excluded people who have a history of myocarditis or pericarditis in the past year because those would not be new cases. For the exposures, we looked at the receipt of an mRNA vaccine as the second dose. So we're just ignoring the first dose for now. We focused only on the second dose, and we started from the period of the start of the vaccination program in December 2020, and we went up till September 9th, 2021. and we stratified them or grouped them by the dosing interval. So we had a short dosing interval of 15 to 30 days, a medium dosing interval of 31 to 55 days, and then a longer dosing interval of 56 days or more, so roughly 8 weeks or longer. And then we also looked at another exposure was whether people had PCR confirmed SARS-CoV-2 infection. And so that was from the start of the pandemic in January 2020 till September 9th, 2021. For the outcomes, we looked at the health administrative data for these 3 provinces. So that's either emergency department visits or hospitalizations that were coded as myocarditis or pericarditis that occurred within 21 days after an exposure. Okay, so next slide, please. So here I'm just presenting the number of people exposed who've had this different exposure. So you can see there are about 13 million people who had Pfizer as their second dose, about 5.7 million people who had Moderna as their second dose, and then 860,000 people who had SARS-CoV-2 infection during this study period. And you can see roughly half were males for all 3 groups. And then you can see that there's a different age distribution. So for infection, you can see that there's more in the younger age group, like the 18 to 29, kind of the young adult group compared to those vaccinated. Whereas for those vaccinated, there's more who are over age 40 than those with SARS-CoV-2 infection. And then at the bottom, by dosing interval, you can see that there's slight differences between those who received Moderna and the Pfizer vaccines in terms of, how many people, what percent of people had the longer dosing interval compared to the medium dosing interval. Next slide, please. And then this is the number of cases that we observed in the study period. So after mRNA vaccine, there are 686 cases. And after SARS-CoV-2 infection, there were 160 cases. So yes, there were more cases after mRNA vaccine, but that's in the context of many more people receiving mRNA vaccine than having SARS-CoV-2 infection. Now, you can also see that there are differences in terms of sex. So there are, there's more males who've had myocarditis or pericarditis after both exposures. And you can see some differences by age group. So for after mRNA vaccine, it skews more towards younger age groups, whereas after SARS-CoV-2 infection, you can see a greater proportion of the cases were in the older age group. And then there you can also see the dosing interval. There seemed to be more, just the distribution of the cases by dosing interval. Next slide. So now we're presenting the incidence per million. So that's the vertical axis is the incidence per million. So it's how many cases we see per million people exposed. So on the left-hand side, you see the data for males. On the right-hand side, you see the data for females. And then on the horizontal axis, you can see the different groups. So you can see the exposure for infection. It's the gray bar. And then on the right-hand side, within each plot, you can see the incidence by the different vaccines, and then further broken down by the dosing interval. And so you can see here for those age 40 years or older, you can see a much higher incidence, of myocarditis or pericarditis after SARS-CoV-2 infection than after mRNA vaccines, and especially so for males. Next slide. Next, we're looking at those who are age 30 to 39. We can see that the incidence of myocarditis or pericarditis is still higher after infection than vaccination for females, and among males, for Pfizer recipients. And then for Moderna recipients in males, it looks like it's about equal, between infection or after vaccination. And there seems to be a trend with, higher for the shorter dosing interval and then slightly lower for the longer dosing interval. Next slide, please. And then moving down to the 18 to 29, you can see there that the incidence of myocarditis and pericarditis goes down after infection compared to the older age groups. And then there seems to be a higher incidence, especially after Moderna vaccine in males. You can see that the incidence is fairly high, quite a bit higher for, especially with a short dosing interval of 15 to 30 days. And that's not seen in the females, with this elevated incidence that we are seeing in the males. And there also is some elevated incidence in the Pfizer recipients as well among males for the short dosing interval. The next slide. And then lastly, for those who are aged 12 to 17, we've only presented the data for the Pfizer recipients because there are very, very few Moderna recipients in this age group. You can see that the incidence is comparable, whether after infection or vaccination, a suggestion that it may be higher after vaccination, but that the confidence intervals are quite overlapping, so it's hard to be definitive there, and very few cases among females. Okay, so next slide, please. So some of the limitations of these data are that the outcomes are obtained from health administrative data, and they're used using just ICD diagnostic codes. So we just don't know the validity of these codes, and we didn't review the charts to confirm the diagnoses. However, along with some colleagues at Public Health Ontario, we've also done similar work as this, where we use results of passive surveillance with clinical review of the records. And we got exactly this, basically, very similar results. And you can look on medRxiv for that, for those results. And it's also been accepted at a journal. So we'll be coming out soon. Now, the second limitation is that we're missing cases of myocarditis and pericarditis who don't seek medical attention. And also, we're also missing those if someone had a SARS-CoV-2 infection that wasn't confirmed by PCR and had myocarditis or pericarditis, we don't have that as well, because we're not able to say those people had it after infection if we don't know that they had the infection. And then the third point is that these are very rare events. The incidents that I was presenting were per million exposure, so extremely rare, and that led to the wide confidence intervals. So, even though we're following, like 27 million people across these 3 provinces, sometimes, for some of these strata that I was presenting, there were only like, 1 or 2 events, and so it was really hard, even when we combined across the 3 provinces, to get very stable estimates in these incidents because these events were so rare. So you really need, like tens, if not hundreds of millions of people to study to confidently estimate these incidents. Okay, next slide. So in conclusion, it's pretty clear that the incidence of myocarditis and pericarditis is higher for males and females after the Moderna vaccine compared to after the Pfizer vaccine. And it seems to be after shorter intervals compared to the longer dosing intervals, especially for those aged 18 years or older. It's also higher after SARS-CoV-2 infection compared to after mRNA vaccines, especially for adults older than 40 years or older. But the opposite is seen for males aged 18 to 29 years who receive the Moderna vaccine. So there can be some programmatic strategies that we can use to reduce the risk of myocarditis or pericarditis following mRNA vaccines. So for example, we could avoid the use of Moderna for adolescents and young adults, which is what has been done in Canada and in other countries where we haven't recommended it for those aged 30 years or under. We could also use a longer dosing interval, which may also help to reduce the risk somewhat of myocarditis and pericarditis. Now, I think the last key point I want to make is that it's really important that when you make these risk-benefit decisions about COVID-19 vaccination, you need to account for the other outcomes beyond myocarditis and pericarditis. So here I've only presented the data for this single outcome, but really there's so many more outcomes that can be caused by SARS-CoV-2 infection that need to be taken into consideration. It's not just about the myocarditis risk that seems to be the main serious side effect of the mRNA vaccine, but there are many other severe consequences of infection that need to be taken into account, as well as the less severe, consequences of just infection. There's lots of social and economic disruptions of getting infected. As well, there's also risks to those around those who are infected. So just because a young person can get infected and they don't get very sick, but they can pass the infection on to somebody who's more vulnerable in their lives, and that person could also suffer a severe consequence. So there's all these considerations besides just the risk of myocarditis. Okay, next slide. Okay, back to you, Tim.
Great. Thank you so much, Jeff, for those findings and that explanation. We're going to switch gears a little bit to look at another at-risk population, which are pregnant people. And in this context, just some of you who are listening may have tuned into the CAN COVID seminar we had on vaccine safety in pregnant people in December. And at that meeting, we presented results that one of our investigators, Deb Mooney from University of British Columbia, presented on this slide, which was the recognition that pregnant people had a greater chance of severe outcomes from COVID. And on this slide, you can see that pregnant women with SARS-CoV-2 infection had a much greater chance of either being hospitalized or admitted to ICU relative to non-pregnant women of the same age, 20 to 49. And you can see the risk ratios being 2 to 5 times higher for hospitalization and ICU respectively. So a very important a risk group to manage. And at that time, there was back in October, over 98% of hospitalized pregnant people were unvaccinated or incompletely vaccinated. Well, today we have Dr. Bettinger, who's about to publish a manuscript who has new results on vaccine safety and specifically on adverse events during pregnancy. And so, Dr. Bettinger, we're eager to hear your findings.
Great, thanks, Tim. Next slide, please. So again, I'm going to be presenting data from our Canvas COVID study in which we look specifically at pregnant people who enrolled in the study. And so what this slide is showing you, it's somewhat complicated, is essentially the three groups that I'm going to be showing you data from. So the first group are pregnant vaccinated individuals, and they were vaccinated with either the Pfizer or the Moderna vaccine. So we'll call them the mRNA group. And you can see the number that we have the surveys from after each dose. The next group that we looked at would be non-pregnant vaccinated individuals. And we restricted this group to females to make them more comparable in terms of the ability to be pregnant with our pregnant vaccinated group. And so again, you can see the sample is much larger for both dose 1 and dose 2. And then the third group that we have is our pregnant unvaccinated control group. So these would be individuals who are pregnant but did not get the vaccine. So if we look at sort of the health events, and again, this would be an event that prevented daily activities, caused work absenteeism, or led to medical care, you can see the rates after each dose 1 and dose 2, and they're almost equal between our pregnant vaccinated group and our non-pregnant vaccinated group. And you can see though, for both groups, they're actually slightly higher than what we see in our pregnant unvaccinated control group. Next slide, please. So specifically, and I think maybe a lot of you on the call are quite interested in knowing, well, what does it look like in terms of pregnancy complications and miscarriage? And so one of the strengths, I think, of these data is that we are actually able to look at these outcomes in both pregnant people who were vaccinated and pregnant people who were not vaccinated. And you can see going down here that the rates are actually very similar in both groups, which in fact, miscarriage is slightly lower in our vaccinated pregnant group. Next slide, please. So what were we seeing in terms of symptoms being reported by pregnant vaccinated individuals? So lots of injection site reactions, almost 80% after dose 1 and dose 2 of pregnant people experienced pain, swelling, or redness at the injection site. And if you think back to the data I showed you on children, this is quite a bit higher. What sort of symptoms were they reporting, though, for those that actually did experience something? So we can see a lot had the fatigue, muscle ache, and feeling unwell, about almost 3% after dose 1, and it jumps up to 6% after dose 2. So you're seeing an increase after that second dose of vaccine. And then a lot of headaches or migraines. So about just over 2% after dose 1, and again, doubling 4.5% after dose 2. So that's in our pregnant group. In our unvaccinated pregnant people, you can see the rates of these events are quite a bit lower. Not barely reaching 1% and 0.6%. Next slide, please. Okay, so I'll try to walk people through this, and I hope it's not too complicated. So this is essentially comparing our pregnant vaccinated group to our unvaccinated pregnant group. And by doing this, we're able to adjust for their age, their trimester of pregnancy, and whether or not they had a previous COVID infection. So in a sense, it makes our two groups more comparable. And so when we're looking over here on the left, this sort of first set of graphs, this is any health event. So this would be any event that prevented daily activities, caused work absenteeism, or led to medical care. So the top box is either any mRNA vaccine, so Pfizer or Moderna. The middle box is Pfizer, and this lower box is Moderna. The dotted line is showing you that's 1. So if the estimate ends up being 1, then it's the same in both groups. And it's only considered significant when the lines cross this dotted line here. So the lines are our 95% confidence interval. The little point here is the actual estimate. So sort of taking you through this first box, what we see is for any mRNA vaccine, the association of a health event that our pregnant vaccinated women were not more likely to have one of these events after dose 1. We see a slight uptick, though, in dose 2. So in our pregnant vaccinated group, they were more likely to report something following dose 2 compared to our unvaccinated pregnant group. However, we see for the Pfizer vaccine no difference in our vaccinated pregnant people and our unvaccinated pregnant people. Where this sort of association is coming from, both for any mRNA vaccine, but specifically with the Moderna vaccine, is after this dose 2. So dose 1 Moderna, no differences. Dose 2, you do see a difference in pregnant people who had dose 2 Moderna. They were more likely to report having an event that prevented their daily activities, caused them to miss work, or caused them to seek medical care. So then what does this look like in terms of these events? What type of medical care did they seek? So these boxes here, we were looking at, how frequently they had an emergency department visit or hospitalization, how frequently the event led to that. And again, it's quite reassuring because what we see here is actually no difference for any of the mRNA vaccines, or in particular the Pfizer vaccines, in those health-seeking behaviors. And even when we look at Moderna, we don't see a difference. I think it's important to note our sample size does get small, thus the very wide confidence intervals on these estimates, but even the point estimates are close to 1. So what can we conclude from this? In our pregnant vaccinated group and our pregnant unvaccinated group, we did not see a difference in emergency department visits or hospitalizations. And we don't see any difference in health events following dose 1 for any of the mRNA vaccines. We did see an increase in vaccinated pregnant people reporting symptoms after that dose 2 of Moderna. And again, if you think back to the slide I just showed you, those events were headaches, they were feeling unwell, and we had lots of injection site reactions, which for this analysis with our unvaccinated group, we can't obviously look at injection site reactions. Next slide, please. Okay, so this is the similar setup, but now we're looking at our vaccinated pregnant people compared to our vaccinated not pregnant people. So what's very reassuring on this slide, same setup, Pfizer is here, Moderna is here, is we're not seeing any differences in our vaccinated groups. So for those individuals, whether they were pregnant or not, they reported the same types of symptoms following their mRNA vaccines. So there was no difference in health events. What we see when we look over here is no difference in our ED visits or hospitalizations for the Pfizer vaccine, but we do see that pregnant people were more likely to seek care following that second dose of the Moderna vaccine. And again, if you think back to the previous slide, we saw that they were more likely to report symptoms following that dose than pregnant people who hadn't been vaccinated. And when they had those symptoms, they were more likely to seek care for them. Next slide, please. So what can we conclude from this? In general, mRNA vaccines are very safe in pregnancy. And I think if you think back to the slide Tim showed with the increased risk of poor outcomes among pregnant women when they get infected with COVID, these data should be really reassuring for individuals who are pregnant and trying to decide about whether or not they should be vaccinated. We didn't see any differences in adverse events following immunization among vaccinated individuals. And we didn't see differences in ED or hospitalizations between vaccinated and unvaccinated pregnant people. We also did not see any differences for pregnancy-related events between vaccinated and unvaccinated pregnant people. And again, I just want to emphasize that point. So for these pregnancy outcomes, we're not seeing differences. We did see that pregnant people are more likely to seek care for vaccine-related symptoms after that second dose of Moderna. And so what this, I think, really tells us is that we probably need to do a better job both educating our perinatal care providers as well as our pregnant patients about what they should be expecting after, in particular, that second dose of Moderna vaccine. So thanks, and I'll hand it back to you, Tim.
Great, thanks so much, Julie. And I'd like to thank all the presenters, but the individuals that have presented today, of course, are part of much larger teams. And I think we all feel it's really important to recognize the collective effort behind this research. And so I'm going to begin with Dr. Top with an opportunity to thank your team.
Thanks, Tim. Next slide. Yeah, so I'd like to thank all the members of the Special Immunization Clinic team, our site investigators, co-investigators, nurses, and our data team at the Canadian Centre for Vaccinology, as well as our funders. Next slide.
Great. And
I'd also like to thank the Impact team, many of whom are shown there, and our funders. Thanks.
Great. Thanks, Dr. Top. And now Dr. Bettinger, you have an opportunity to thank your team.
Great, thanks. So obviously a study that's enrolled over 1 million Canadians requires a huge team effort to perform. So these are some of the names of people who've been involved in this. And I would really like to sort of recognize all of the site investigators and the site coordinators. And really also a huge thank you to our provincial collaborators, some of whom I've named on this slide. Not everyone's listed here, but really this could not have happened without a really close partnership between provincial and territorial public health and the study teams. So thanks so much to everyone for making this happen.
Thanks, Julie. And then over to you, Jeff.
Yes, I'd like to thank the Provincial Collaborative Network study team. So we have teams in British Columbia, Ontario, and Quebec. And so people who were working hard to cut the data sets and then also to do the meta-analyses. So we had our analysts, Julia, Andrew, and Isabel in the 3 provinces, and then Mina, who helped to do the meta-analysis of all the results that we got from the 3 provinces.
Great. Well, thank you. Thank you to our presenters, our investigators, and all their teams. I'm just going to move now to a few summary statements just so that that leads us into the Q&A. First, I think we saw that serious adverse events following vaccination children are very low. So pediatric Pfizer vaccine is extremely well tolerated in children. Less than 3% systematic experience of children experience systemic events after a vaccine. After dose 1, 96% did not develop any health event, and after dose 2, it was 97% that didn't. And there's evidence that adverse effects following vaccination have been much rarer in children than in adults. So that's with respect to children. Moving now on to adults. That there is quite frequent mild adverse events, but serious events are extremely rare among adults. We covered the data earlier on in the presentation of 82 million doses being administered in Canada over the last 16 months or so, and very, very low rates of adverse events, serious adverse events and deaths. The vast majority of adults who had adverse reactions to dose 1 were recommended to receive a dose 2, and the recurrence or the reoccurrence of adverse events was rarer after dose 2. So the number of adverse events reported in Canada after the second, third, and fourth doses are very low. Moving then to the specific focus on one type of adverse event, which is, next slide, please, which is myocarditis or pericarditis. We found that adults over 40 have a higher risk of myocarditis and pericarditis from COVID-19 infection than they do from the mRNA vaccine. And there's recommended a Pfizer vaccination for males under 30, as has been done and seen in other countries. Some would suggest under 40, and also some recommendations of a longer dose interval for adults over the age of 18. And then we moved and had a look at pregnant people, next slide, where we found overall that mRNA vaccines are very safe in pregnancy. This is particularly important because we know the risks, the health risks of infection due to COVID are much more severe in pregnant people, especially if they're not vaccinated. There are common adverse events related to pain, swelling, and redness at the injection site, as well as increased fatigue and migraines and headaches, and also that systemic symptoms and seeking emergency care are more common after the second dose of Moderna. And as Dr. Bettinger said, very important to discuss and offer counseling to pregnant people to optimize the management of expected adverse events based on this evidence. So with that, I think I'd just like to again thank our panelists, and we'll begin with our first question. And I'm getting instructions on from one of our people on what that question will be. So Caroline, where do I begin? So we have a question for Dr. Bettinger, and it begins with this. With the Canvas COVID Kids survey, is the previous experience with infections of SARS-CoV-2 and acquisition of natural immunity tracked, i.e. was serological antibody testing performed? In the UK, as much as 90% of high school students and 60% of elementary school children have been reported to have natural or infection-acquired immunity. Dr. Bettinger?
Great, thanks for the question. Yes, we are tracking this, but just to be clear, the Canvas COVID data is all self-reported. So the question that we ask of individuals, both adults and children, is whether they've had a lab-confirmed SARS-CoV-2 infection and the date that they had that confirmation, like when it occurred, and then the severity. And we give a description for what the severity is that we're looking at. And we're tracking it both in the adults and the children. So to the extent that testing has been performed, we will be able to look at this in the data. I think we're going to have to probably do some sensitivity analysis in the pediatric data, just given that the vaccine rolled out at about the same time that we had that Omicron wave starting, and testing practices also changed. So we certainly have captured it. I just don't know how much testing was being done over the same time period that vaccines were rolling out. So we may have some misclassification going on in our data if kids were infected and asymptomatic and not ever tested. So thanks.
Great question, and underscores the importance of systemic immune testing in the pediatric population as well. Dr. Kwong, numerous studies have shown that the rate of symptomatic myocarditis associated with mRNA vaccines for males between 12 and 24 years of age with their second shots from 1 in 400 to 1 in 9,000. So that's the range and rates. Non-symptomatic incidents may be 3 times more common. How can this be considered as minor? Dr. Kwong.
Yeah, thanks for the question. I absolutely agree that that there is a higher incidence of myocarditis in young males, and I'm not saying that it's minor at all. But I think most of these cases who do experience myocarditis, they may present to the emergency department, and only some of them will end up admitted to hospital. And the hospital admissions that do occur tend to be relatively short, so only 1 or 2 days. So compared to, I think the risk in older people, from getting SARS-CoV into infection, we're talking about can be as high as 5% of people are admitted to hospital. So when we're presenting the case and how many per million or how many per thousand, it's far lower for these young age groups. It seems higher compared to the older age groups, but it is you just have to put everything into context that it is a relatively small risk compared to the harms of COVID-19 infection.
Great, thank you, Jeff. Dr. Top, as you did mention this in your presentation, certain studies have noted that only 1% of adverse events are officially recorded in the medical data. I've also heard of many anecdotes that patients are not taken seriously by their doctors in reporting adverse events. How can we be sure of the validity of the data that is gathered about vaccine adverse events and ensure that 100% of these events are included in the public data? Also, linked to this, the original Pfizer 6-month phase 3 trial reported a 5% adverse events rate. How do you explain such a low rate of adverse events associated with vaccination with the CAFES data that is based on passive reporting? Over to you, Dr. Top.
Great, thanks for the question. So first off, it's important to understand what the purpose of the passive surveillance system is. So we do learn from the clinical trials about what the common adverse events we can expect, those sort of frequent mild adverse events that Dr. Halperin spoke about. And then the passive system is really focused on capturing adverse events that may have been missed in the clinical trials because they're rarer and you need larger populations to have been vaccinated in order to pick them up, and those that require medical attention. So the focus is usually adverse events that lead to hospitalization, emergency visits, and require treatment, including things like anaphylaxis, myocarditis, neurologic symptoms. And so that's really the focus of the passive system. We do know for more serious adverse events that have been linked to vaccination that reporting to the passive system is much better and much higher than 1%, certainly. But it is important for healthcare providers to report adverse events if they suspect them. And we do encourage healthcare providers, public health encourages healthcare providers to report, and most provinces mandate that healthcare providers report adverse events that meet certain criteria like those I mentioned. So that helps improve the completeness of the data in the passive system. But I think also, as we've shown today, the passive system is not the only tool that we use to monitor vaccine safety. And so we have multiple systems, including Canvas, the Special Immunization Clinic Network, IMPACT, that are active surveillance systems, and public health and health administrative data, as Dr. Kwong showed, which where we're actually capturing all cases and then analyzing to see what the rates are after vaccination compared to the expected background rates. And that provides us the most complete picture of vaccine safety.
Great. Thank you very much, Karina. Dr. Bettinger, back to you. How do the rates of mild, moderate, severe AEFI, adverse events following immunization, compare to other vaccines, such as influenza, shingles, and the standard set of childhood vaccinations?
Okay, great. Thanks for the question. So I think probably it's easiest if I speak to our Canvas data. And so this would be comparing COVID vaccines to influenza vaccines, because we've used the same system to capture the information. And so those rates will be most comparable. And so what we see with influenza vaccines in kids is we actually see a slightly higher reporting rate for these events in children following influenza vaccination than what we're seeing with COVID vaccination. And for adults, it's similar. So a similar reporting rate, and in particular, when you start breaking it down, looking at headaches or fever, the actual individual events themselves, it's very similar.
Great, thanks so much, Julie, for that. Now this is for anybody on our panel. And the question is, what Moderna safety data for 5 to 11-year-olds do we expect to have by the time of approval of the vaccinations for the under 5s? And how will this safety data be communicated and disseminated in hopes that the data will demonstrate safety and be encouraging for our youngest cohort of under 5s? And concern because current polling shows 43% of parents with children under 5 have no intention to vaccinate those children. So does anybody want to respond to that in terms of what the Moderna safety data for the children 5 to 11 is showing that might give us some sense of how to manage risk communication to parents in thinking about getting their children under 5 vaccinated? Any takers on that? Scott?
I don't think Scott's on the call at the moment, but I don't think there's going to be that many children age 5 to 11 receiving the Moderna vaccine. So I don't know that there will be a whole lot of data to inform the decision for those parents, with children under 5 on the safety of the Moderna vaccine. But I mean, I think we'd have to rely on the trials and data from other countries as the vaccination programs are rolled out there.
Right. And Jeff, insofar as the majority of children 5 to 11 have had a Pfizer vaccine, is your sense that that risk communication based on the experience of 5 to 11-year-olds will be helpful in making the case to parents with respect to their under 5 children?
Yeah, I mean, specifically for myocarditis and pericarditis, we've seen lower numbers of cases in the 5 to 11 group than we did in the 12 to 17, and that's to be expected, right? We know in that figure I showed near the beginning of my talk that there's a much lower background rate of myocarditis and pericarditis in younger children, and so we have seen fewer cases. I don't know the exact numbers off the top of my head. I'm not so closely involved in the passive safety surveillance work, but my understanding is that it is a lot lower than in the older age groups.
Okay, great. Okay, well, Jeff, while I have you, there is another question that's come up about the several cases. There are several cases of myocarditis in kids 5 to 11 from Ontario Public Health data. What was the outcome of their myocarditis incidents?
Yeah, unfortunately, I'm not able to speak very knowledgeably about those cases. I would recommend reading the report from Public Health Ontario, where they outline as much information as they have. And sometimes this is not available because they haven't finished their investigation yet. But presumably, if they haven't had a severe outcome, like if a child died, that would definitely be in the report. So hopefully, like, it's one of those no news is good news sort of things, where if they didn't say they died, then they probably were fine and they recovered from their myocarditis.
Okay, I'm going to continue on this 5 to 11 age group because there are a few questions on it, and I'll open it up so it's not only you, Jeff, if either Julie or Karina want to jump in. But Jeff, it might come back to you, but because can someone comment on the myocarditis cases reported in 5 to 11-year-olds, first and second doses, please?
So maybe I'll jump in. I think the occurrence of cases have been, they're extremely rare, particularly in the 5 to 11-year-olds. And so it's quite challenging to make any sort of comments on 1 to 2 cases that you're seeing, at least in the passive surveillance system. I don't know, Jeff, if you want to add more, because you've obviously looked at this data in more detail than I have.
Well, I would just say that, like, there's one more question here about, are there fewer cases just because there are fewer kids who are vaccinated? Well, definitely when they are reporting these cases, like the incidents, they're looking at like how many million doses have been given. So it is kind of standardized by the number of people who have been exposed. And so based on that, like, there is a lower incidence in 5 to 11 compared to 12 and older. So there's definitely like a fewer absolute number of cases, but also a lower rate in terms of the incidence as well.
Right.
But that's about it that I can say about it.
And maybe if I could just jump in, the data out of the US, which would have much larger numbers of children that age group being vaccinated, also supports a much lower rate of myocarditis in that 5 to 11-year age group after the first and second doses compared to adolescents, and also that they have done well. So the outcomes are really good, similar to or better than the teenagers.
Okay, great. Thanks. And I think perhaps a final one on the 5 to 11 age group is when is the booster expected for the 5 to 11-year-olds? 2 doses are not protective against infection.
So I think we're waiting on the clinical trial data around that in that age group, and certainly once it's submitted to the regulator and reviewed, I think then recommendations will be coming out around a booster dose.
Okay, great. Dr. Top or Dr. Bettinger, which proportion would you say that the reactions after vaccinations are undervalued? We would have had to meet our doctor to declare the reactions, and our doctor is not accessible. So I think this issue of inaccessibility of doctors, what proportion of people are perhaps not reporting reactions after vaccinations because they can't access their doctor?
Well, I think that's hard to say specifically, but there's always ways that people can seek, medical attention if they have health events, new health events after vaccination or at any time. So even if you can't get into the family doctor, there are walk-in clinics, emergency room. And so, certainly anyone who has symptoms that are concerning after a vaccination, and they should seek medical attention and let their provider know that they had a vaccine. Sometimes providers may forget to ask, and that can also be, lead to events not being reported that perhaps should be.
Yeah, and Tim, and maybe I'll add something here, and it comes back to an earlier question we got, was someone was concerned that we weren't capturing 100% of everything. And I would just say, I don't think we need to capture 100% of everything to have a sense of what's happening with vaccines. And the point is not really to capture 100% of everything. It's to make sure that you've got representative groups that you can then generalize information to individuals where maybe you don't have information from. And that's how we do all of our health studies studies where you take a sample and you make sure it's a good sample, and then that's reflective of what you're seeing in a larger population. So this idea that we need to be capturing every single thing, I think is a bit of a misconception.
Yeah, great. Thank you for that. And I'm going to move back to Dr. Kwong. There's continued interest in myocarditis, and the one question is whether you know of any data of myos or pericarditis after the Nuvaxovid and Medicago vaccines. And I think, Jeff, you have indicated that lower rates of myocarditis in 5 to 11-year-olds because there have been many fewer kids in that cohort have been vaccinated. You've already answered that question, but that just to mention that that was there. So perhaps, Jeff, if you can comment on the first part of that related to these other vaccines and myocarditis risk.
Yeah, I'm not aware of any data on the risk of myocarditis after the Medicago or the Novavax vaccines. I think there's too few Canadians who have received these vaccines to really look at the myocarditis risk, given how rare myocarditis is. But maybe if more people are receiving these vaccines in the coming months, we'll be able to look at that.
Yeah, great. And a further question on myocarditis, which is, could someone comment on the clinical outcomes of myocarditis from natural infection compared to myocarditis as an adverse event from immunization?
I don't have those numbers off the top of my head, but so I don't think I want to comment and cause any misinformation.
Okay.
But that's something that we're gonna. Sorry, I'll just say that is something that we're gonna look at. We do have like the average length of stay, whether it's after vaccination or versus after infection, and I just don't have that right in front of me at the moment.
I guess if I could just provide some context, which I think gets back to a point that Dr. Kwong had earlier about looking more broadly than just myocarditis after vaccination. In children 5 to 11 are the group where we see multisystem inflammatory syndrome in children most frequently, and that many of those children do have inflammation of the heart, myocarditis, or inflammation of the blood vessels around the heart. And we do know that vaccination prevents that. So the risk of MIS-C is certainly higher with vaccination, and many of those kids end up hospitalized and in ICU compared to myocarditis, which has been very mild, and certainly ICU admission being very rare.
Great. Thank you, Dr. Top. And because you answered that so well, I'm giving you another question. Has anyone looked to see if those who tolerated dose 1 then have subsequent anaphylaxis/allergic reactions with dose 2 for any of the mRNA vaccines? So you reported data, I think, on anaphylaxis following dose 1, but this question is really focusing on anaphylaxis allergic reactions with dose 2 for any of the mRNA vaccines.
Yeah, thanks for that. So we certainly in the special immunization clinic network, and we're receiving referrals from people where there is a concern about anaphylaxis or allergic reaction, but there may not have been, but it may not truly be an allergy. With those, we saw far fewer referrals after the second dose compared to the first dose. And I think overall what we've seen over time with anaphylaxis rates is that they've stabilized to closer to the range that we see with any vaccine, and are similar between viral vector vaccines and mRNA vaccines. So there does not seem to be a particular higher chance of anaphylaxis after second dose mRNA or a booster compared to after a first dose.
Thanks very much, Karina. Dr. Bettinger, do you have any advice on how health system leaders can increase vaccine uptake amongst pregnant people?
Great question. So this is an area of active research for me. We could almost have another session on it. But in general, I think, and this is true not just for pregnant people, but for parents and for adults, I think one of the most effective ways that we can have individuals get vaccinated is having a conversation with a trusted healthcare provider. That shows up study after study after study that this is really oftentimes the number one, if not the only reason someone decides to get vaccinated. So I think in terms of our pregnant population, really ensuring that our perinatal care providers, and this is all providers, obstetricians, midwives, family doctors, nurses, are comfortable having conversations about vaccines, comfortable asking questions, and comfortable providing some counseling on this. And then I think the second piece is really making vaccines available, because in some regions and some jurisdictions, it can actually be quite challenging to get a vaccine if you're pregnant. They're not always offered or given by the perinatal care provider, so it requires going somewhere else. Sometimes you have to get a prescription and then find a pharmacist who will deliver it. And so there's all sorts of a mixture of the way that we deliver these vaccines. And, if you have someone who's slightly hesitant, or even maybe not hesitant, but just doesn't have the time to deal with it, that's often where we're losing people. We don't make it easy for people to get vaccines. And I think, at a health systems, health leader level, the more that we can sort of eliminate those types of accessibility barriers, the better result we're going to have in these populations.
Yeah, thanks very much, Julie. So there are two more questions that have come in with respect to different types of populations and adverse events. So the first one is, are adverse events happening due to the health of the recipient? Are there underlying health factors that contribute to adverse reactions? Also, are there other types of reactions from the vaccination that are not the focus of these studies? Anybody want to take a crack on that at that? So these would be concomitant health conditions that individuals may have, and do we find that they have a higher incidence of adverse reaction, or what is the incidence, or is there any difference?
So maybe I'll go first, and I can just say for the Canvas COVID data, we did collect information, as I already said, sort of on people's health status, as well as specific questions around whether or not they were immunocompromised or had an autoimmune condition. And we haven't analyzed those data yet, but we have plans to do that. That's on coming up in sort of our next set of analyses, probably over the summer. So I would expect we'll have some data out on that maybe by the fall. And then I think there's as well some other CITF funded studies where they're looking. Ours is going to be sort of a very general look at this, because the focus of what we were doing was not on these populations, but we wanted to be able to at least get a sense if there were signals in these populations. But I think there's other more detailed studies that are actually going on in some of our groups. The transplant group is one that comes to mind, and Karina or Jeff might be able to comment, or even Tim, you might have some comments on some of the other populations that are being looked at. Thanks.
Okay, Karina and Jeff, do you want to supplement that in any way?
Yeah, I just to echo what Julie said, that there are a number of people, different groups of patients with immunocompromising condition, a range of immunocompromising conditions are the subject of other CITF studies, so we'll have safety on that. I guess just into the last part of the question about other types of reactions from vaccines that aren't being focused on. There's certainly have been discussions around a range of different types of health events that have popped up after vaccination around the world. And we're investigating all of those. A few that have been identified that we're still working through to see what is really the risk after vaccination, include things like Bell's palsy, sort of weakness, facial droop that can occur after the mRNA vaccines, and the Janssen and AstraZeneca vaccines have been associated with blood clot and bleeding disorder, which is why we use those much less now in Canada and focused on mRNAs.
Great. Well, thank you very much. And we're at 12:59 and have come to the end of our of our time, but just to comment, a fantastic set of presentations. Congrats to the PIs and their teams, and thank you for sharing today. And thank you for a very extremely active audience with all of the questions that have been submitted. I'd like to thank today's speakers and attendees on behalf of CITF and CAN COVID. And for contributing to this important discussion. Our next event in this series will be in June, so please stay tuned for more information. If you're interested in the presentation, a PDF version is now available on CITF's and CAN COVID websites. You will also find a summary of the presentation on our website in the coming days. The event's recordings will also be available. Finally, you will receive a request to fill out a brief survey about today's events. Please do take a few moments to fill it out, as your feedback would be very helpful to both CITF and CAN COVID in planning future events. So that's all for today. Again, thank you to everyone for your participation. Take care, and we look forward to seeing you soon.
We would like to thank today's speakers and attendees for their time, as well as the members of our networks for their continued support and participation in Canada's pandemic response. If you are interested in attending our monthly research results and implications events, please visit either website for more information.